All right. So welcome back, everybody, to the Ketamine International Journal Club. Today, we have Fabrice Jolin talking about their very recent paper published on the Journal of Affective Disorder. You can see the title already on screen, Clinical Predictive Factors and Trajectories of Suicidal Remission over 6 weeks following intravenous ketamine for suicidal ideation. So I'll let Fabrice take over and maybe tell us a bit about himself, his work, and the paper. If you have any question during the presentation, just please pop them in the chat below. We'll try to answer them in the order they arrive. And again, before we start, just another reminder that we have the Ketamine conference coming up at the end of March, from the 25th to the 27th of March here in Oxford. If you're interested, there are more information on our website, ketamineconference.org, and we still have some slots, and we would be delighted to see you over here in Oxford. Anyway, enough from me, and I'll just pass the microphone to Fabrice. Thank you.
Thank you. Thank you very much. And thank you for the invitation to talk today about this article. Just wanted to start by saying that I'm at home and I'll probably be interrupted by a delivery. So that I've been expecting for the whole day, and I expect it to arrive during my talk. So this is a paper entitled Clinical Predictive Factors and Clinical Trajectories of Suicidal Remission over 6 weeks following intravenous ketamine for suicidal ideation. This is a paper about secondary analysis of another paper published 2 years ago. I'm going to come back to this. First, to say that I have no conflict of interest to disclose. So the main study was published 2 years ago in the British Medical Journal, and it was ketamine for the acute treatment of severe suicidal ideation, double-blind, randomized, placebo-controlled trial. So it's a trial called KETIS, which was a multicentric study in 7 academic centers in France. Conducted by Dr. Abbar in the Academic Hospital of Nîmes in the south of France, and publicly funded. So what we did was to add ketamine or placebo as an add-on treatment. Ketamine was given as an IV infusion over 40 minutes, so classical 0.5 milligram per kilogram. And at the time when we wrote the protocol, we thought it would be a good idea to have 2 IV infusions at 24-hour interval, but it was really not based on any scientific evidence. And we can go back to that in a minute. So the follow-up was 6 weeks, and the main outcome, and this is important, was a full remission of suicidal ideation at day 3. So we did not expect just a response, but a full remission of suicidal ideas. And this was measured by the classical Beck Scale for Suicidal Ideation, the SSI, and remission was defined as a score below 3. In the whole population, but also per diagnostic group, which were recruited a priori, and the 3 groups were bipolar disorders, major depressive disorder, and other affective disorders. So we calculated to be powered to show a significant effect per group. And there were, of course, secondary outcomes like short-term tolerance, other kind of measures, and remission rates at 6 weeks. These are the main inclusion and exclusion criteria. So only adults, hospitalized at the time of inclusion with suicidal ideas, and we excluded people with schizophrenia, other psychotic disorders, or psychotic symptoms at inclusion, substance dependence, positive urine screening, pregnancy, breastfeeding, and stable somatic conditions. So we recruited 156 participants, 83 received placebo and 73 ketamine. 3 discontinued treatment during the first 3 days in the placebo group. And at the end of the study, at week 6, around 80% of participants were still in the study. So it was, as expected, a population with a high suicidal risk, and you can see that on different measures. For instance, the SSI, clinician rated, but also for SSI patient rated. Based on the MINI, for instance, you can see that more than 85% of them were considered to have severe suicidal ideas. Many of them had high levels of psychological pain with a median score of 8. It's a scale on 10. Patients also had high levels of hopelessness, and more than 85% of them had a previous history of a suicide attempt. So this is the main finding, the suicidal remission rate at 72 hours. It reached 63% for people who received ketamine. So you see the first infusion here and the second infusion here. As expected, there was a strong effect after the first infusion. But the remission rates continue to increase over 3 days to reach 63%, as compared to 32% in the placebo group, with a significant group difference. At week 6, there was no more group difference, mainly because the placebo group improved to reach 56%, as compared to 70% in the ketamine group. A second important finding is that there was an important effect of comorbid disorders. So the effect of ketamine was much stronger in people with bipolar disorder, with a lower placebo effect and a higher ketamine effect, as you can see. For an unknown reason, it was not significant in major depressive disorder and almost significant in other affective disorders. There was a good tolerance within the first 72 hours with 10% sedation and depersonalization, derealization, almost 70% nausea. And importantly, we did not observe any hypomanic or manic episode or psychotic episode, and no increase in suicidal ideation in any patient. And finally, we hypothesized that the effect of ketamine would be mediated by an antalgic effect on mental pain. So we measured psychological pain, mental pain with a scale we've developed several years ago, which is an analog visual scale, or visual analog scale, PPPVAS. And what we found in mediating analysis is that ketamine has a strong effect in terms of change in mental pain, which was highly correlated with change in suicidal ideation. And the effect between ketamine and change in suicidal ideation seemed to be mediated by mental pain, as hypothesized. So to come back to this paper published this year, we were very interested in what's happening at more individual level and how it could be useful for clinicians. So to assess more individual level of investigation, if you want. So the two objectives were to identify clinical predictors of response at day 3 and week 6, and to investigate individual trajectories over this 6 weeks in terms of clinical outcomes. So the outcomes were remission, defined as an SSI score below 3, or response as a 50% reduction as compared to baseline, or no response at all at 5 time points, day 1, so 24 hours after the first infusion, just after before the second infusion, at day 2, at day 3, at week 2, and at week 6. So the first findings, first objective, the clinical predictive factors. So we assessed the diagnostic group, remember bipolar disorder, depressive disorder, overactive disorder, age, gender, body mass index, psychological pain, physical pain measured with the same scale, SSI score rated by the patient or by the clinician, hopelessness, depression score, clinical global impression, and a history of suicide. So these were the variables we assessed in univariate analysis, and only diagnostic group, SSI measured by the patient, and physical pain were associated with a change at day 3 at univariate level with a very liberal threshold. But in multivariate analysis, as you can see, only 3 variables survived. So the strongest was bipolar disorder as compared to depressive disorder. So the effect was much higher in this later group. Also, higher level of physical pain, and surprisingly, a lower level of suicidal ideation. At week 6, no variable was significantly associated with a suicidal remission. So it was a bit disappointing to see that so few clinical variables could predict remission, but maybe it's not so surprising because it's usually the case in psychiatry. Regarding trajectory, this is what we observed during the first 72 hours. So you have here day 1, day 2, day 3. The blue line represents the our remission threshold. And as you can see, many patients reach remission very quickly and remained in remission at day 3, while others never reach remission, and some relapse after sometimes. So very complex number of trajectories. So we tried to, first, this is what we observed for the 6 weeks. So again, large number of patients reaching remission very early. Some remained in remission, some relapsed, and some did not respond at all. Some responded without reaching any remission. So we tried to simplify that to make it more functional, and so what we did was to investigate all possible combination of clinical response. Okay, so 0 is a lack of response, 1 is response, and 2 is remission at day 1, day 2, and day 3. So what we find is first there is a group of people, almost 42 patients in the ketamine arm, which reach remission at day 1 and remain in remission at day 3. Okay, and this is much higher than in the placebo arm, where we could only find 10% with this pattern. The second group here are people who had no remission or no response at all during the 3 days and after 2 infusions. So it's 10% in the ketamine arm versus 34% in the placebo arm. So it means that overall, almost 48% of people in the ketamine arm had some kind of fluctuating pattern. Interestingly, it's higher, it's lower, than in the placebo arm. A second thing is that we calculated the positive predictive value and the negative predictive value. So the question was, when you're in remission at day 1, what is the probability that you remain in remission at day 3? And the PPV is, as you can see, almost 97%. So 97% of people in remission at day 1 will remain in remission at day 3. The negative predictive value, which is when you're not in remission at day 1, what is the probability that you are still not in remission at day 3? And you can see that this value is also quite high, around 80%. One last thing we checked, so these are the secondary analysis of all of that, but it was really the objective of this paper to go deeper into details. But we checked people who are in remission at day 3 in both groups, placebo and ketamine. And what we found is that among people who are in remission at day 3, only those who are in remission at day 1 differ from placebo. So suggesting that actually the main difference between the ketamine arm and the placebo arm is observed as soon as day 1. I don't know if I'm very clear. Yeah, okay, not very clear. But so the idea was, if we take all people who are in remission at day 3, okay, which is our main outcome, and then we check who among them were in remission at day 1 in both group, what we found, as it's written here, is that 70% were in remission at day 1 in the ketamine arm, and 35% in the placebo arm. And it's not obvious, okay? We could, in those who reach remission at day 3 in both group, they could be reached at the same time, at day 1 or at day 2, or only at day 3. And this is not what we observed. Actually, the difference is observed as soon as day 1, and then there is no difference between the two groups. So this difference, this global difference in terms of remission at day 3 is mainly driven by people who are already in remission at day 1. And I think this has some clinical implications we can discuss later. If we do the same thing, so compute this combination of clinical response at day 3, week 2, and week 6, we have different profiles here. And again, we have a group of people who are in remission at day 3 and remain in remission at week 6. And they are, as you can see, 43%. And then we have a group who are not in remission at day 3 and will remain not in remission over the following weeks until week 6. And there are 7% in the ketamine arm, and a fluctuating pattern in 50% in the ketamine arm versus 71% in the placebo arm. So again, we calculated the PPV and NPV, and we get almost the same values. So people in remission at day 3 are very likely still in remission at week 6. It's a little bit less the case for people who are not in remission at day 3. Some will reach remission at week 6, but many will not. So the limitation of the study is, at first, the study was not powered to run complex prediction models with interactions. Some reviewers said, well, we could do that, but it was not possible. I think another main limitation that our main outcome is based on a classical scale, the SSI, widely used in suicidology. But that is not designed to measure repeated time points, right? And notably very close time points. There is still the issue of blinding. With ketamine's classical issue, especially we used a placebo. And also patient could have changed in their treatment. So some clinical variations may be due to this change in, other treatments. And finally, all patients were hospitalized in academic centers. So we are not sure that what we observed in terms of trajectories could apply in other psychiatric hospital or in day hospital, or if the initial infusions were given in emergency rooms. For the clinical discussion, I think our study showed that there is a benefits of ketamine within the first 3 days, and only the first 3 days. And this is very in agreement with previous meta-analysis. So it's an interesting treatment in the very short term, although the benefits could be prolonged in people who responded. We are not sure that the second infusion is interesting, is useful. It should be specifically tested. As I shown, there is, based on our finding, there is limited prediction capacities based on baseline variables, except maybe for bipolar disorder. So the recommendation would be to use it in all patients who are eligible and not select groups. So patients eligible means with affective disorders, adults, and no contraindications, and also use it in bipolar disorder because apparently it works and with limited risk. We found that around 40% will respond very quickly, will reach remission, and will maintain remission over 6 weeks. So this is very interesting. I wrote may guide organization of care in the short term because I think that based on these findings, the fact that people who are in remission as soon as day 1 remain in remission is how can I say, encouraging, and for clinicians it's reassuring somewhere to think that maybe we can discharge patient quickly and follow them in consultation, for instance. However, it should be noted that in 50% there is a more fluctuating pattern with remission or response that can be lost. So we should always be vigilant. And in 10% there is no remission at all. So clearly we need to find new treatments. And at the moment in France, we are conducted another multicentric study in the same indication, suicidal ideation, using buprenorphine. So a different molecule with a different pharmacological mechanisms, but with the same hypothesis that buprenorphine would reduce mental pain and secondly, and as a consequence, suicidal ideation. So we have recruited more than 1/3 of patients. So it's well running, and we expect to have findings in 2 years. So thank you for your attention, and I'll be happy to answer any questions and interact with clinicians and researchers on this topic.
Thank you very much, Fabrice. A very clear presentation and such interesting findings. I think we already have some question in the chat, but I wonder, if our attendees feel comfortable and if they want to ask them directly to you, Otherwise, I'm happy to read them out. I think the first one is Tiago. I don't know if you should be online, Tiago. I don't know if you want to ask them or if you can just read them out. It's up to you.
I've noticed in the first slides that one person in the placebo group died. Any related cause to the trial or for suicidal ideation?
No. No, it was not related to suicide.
And if there is any difference from the age group and the response, we have several real-world data showing that people with above 60 years old, they tend to respond slower. So after 3 or 4 infusions at the end of the 6th infusion period, and younger people tend to respond on the first infusions. Do you see any relation with the age as and the response on suicidal ideation?
No, when we analyze it, as I showed you in the table, it was not predictive of remission, but probably we should investigate it in a different way. So there was apparently no linear association between age and remission rate. But your question, yeah, suggests maybe we should assess by age category. We may find different things.
I've seen both on Patrick Oliver last conference on ASKP. He said that older ages they respond better, but takes more time. But when they do, they get better than the young age, and usually around 6 years old is the limit. Above 60 years old, usually people tend to respond further on the treatment, 6, 7, 8 infusion, and younger people tend to respond on early on the treatment. And I found this on my cohort of patients as well, and I see that above 60 years old is a little bit harder, and it takes more infusions to get some response.
Okay. We could easily check that. I think I don't remember how many participants above 60 we have. They are all adults, but probably would be interesting to check the category of 18 to 24 years old.
Sorry to interrupt, Tiago, were you referring to this specifically for the suicidal ideation or more in general in terms of clinical response? Because I think Fabrice's work was very much focused with on SI, right? While I think a lot of the data that we have, and I'm thinking of, the Ketamine versus ECT trial, they were focused on clinical response in general in depression. So I was curious to hear what's your experience?
In general, all the items, they tend to take a little bit longer to respond on older persons. Even suicidal ideation, whole depression. So the data I have in my mind right now that I recall Patrick Oliver saying, and the data that I have on my patients, they are overall. They are not specifically for suicidal ideation. What Oliver showed us with 10,000 infusions is that with more infusions, people tend to get better from suicidal ideation, even those that do not respond on the first or the second one. And there is an age-related, for him, the age-related was positive. For me, it's negative. So I would like to see more age-related data so we can understand better if we should go to something else above 60 or stay on ketamine under 60. That division would be great to understand better.
Yeah, it can easily be done. Yeah, study the dynamic of response according to age group would be very interesting. I did not speak about that, but we observe the fastest response in bipolar disorder.
Faster in bipolar.
Yeah, so not only they respond more, so the remission rates are higher, and the placebo rate remission rate is lower in bipolar disorder, but also they tend to have to be more often in remission at day 1. So after the first infusions, we respond very, very quickly.
I believe that who has clinical experience can see that some patients, they take 1, 2, or 3 infusions, then they start to drop their levels of depression. So it takes some time sometimes. It's not in the first or the second, but it's not the idea of this work, I understand.
No, but we are very open to all ideas to continue the investigation. We have this data. We have the main results. That's fine. Median, it's fine. It's very encouraging, but I think we need to explore more into details for clinical practice. And this second paper was really aimed at clinicians. So what should we do? What should we expect? Are there some subgroups we could investigate? Yeah.
I think age is one of my biggest concerns.
Yeah.
Thank you.
If I could just make a comment. Hi, everybody. Lisa. I think nosology, is the missing link between studies done across all the countries, where we look at ketamine and related compounds. I make a very big distinction between major depressive disorder with anxious distress, major depressive disorder, GAD by itself, and the various categories of bipolar disorder. Did you in the study look at like how were you comparing apples to apples in sort of like this patient cohort with their depression? Because us clinicians, we know that the gradation of the patients and the flavors that we get in terms of the patients and the definition of what is termed as suicidal ideation in the cohorts vary based on their classification.
Yeah, well, we stick with classical categories, diagnostic categories. And first, it's difficult to have a project outside of that, right? Just for reviewers.
Yeah.
But it's, again, just like age category, it's probably a good idea to now go into more details in terms of clinical presentation at baseline and see if some clinical profiles could respond more. I think it was interesting to have this first finding that comorbidity may have a strong effect on ketamine response in terms of suicidal ideation response. And this is quite new. Usually we tend to study major depression on one side and a few studies investigated bipolar disorder on the other side. And we did both. And even this third group is very interesting. So the group with affective disorder but not responding exactly to the criteria of bipolar disorder or MDD, and it seemed like we could get an interesting response in many of these people.
Have you looked at this? I saw on one slide, I don't know if you could put it back up. I was trying to parse out the numbers on lithium. I saw 4 and 2 within the bipolar group, if I saw that correctly.
Yeah.
In terms of yes, there it is, 4 and 2. Okay.
Yeah, there are very few patients receiving lithium, although I think 20 in each arm suffers from bipolar disorder. So clearly so others had an anti-epileptics, you see, 12 and 5, or an antipsychotic as a mood stabilizer. But I think in France, like in many other countries, the recommended treatments are not followed, so, which includes lithium and clozapine. And there have been some epidemiological studies showing that. So yeah, I was speaking about that earlier. It's that even for ketamine, many clinicians in France are afraid of using it because there is this tag of drug, street drug. And so they really fear using it. And I think it's normal to be cautious, but however, we have data, and finally we have a treatment with some kind of more specific effect on suicidal ideation. Although what we tend to do at hospitals, and probably the same in many places, is that when we receive a very suicidal patient, we give them sedative treatments and we wait that the suicidal crises go down or disappear. And there are some scientific literature showing a significant effect of benzodiazepine in terms of increased risk of acting out. And still we use them because we consider them safer than ketamine or antipsychotic, although there is no proved effect of antipsychotics in terms of suicide ideation reduction.
Yeah, I mean, let's start all the way at the beginning, where when we hospitalize a patient, we think the efficacy of an oral antidepressant that takes 4 to 6 weeks to start working magically starts working because we titrate it. We have 3 days on inpatient. Let's go from 40 to 60, and it's doing something. So it's like, I guess it's physician perception, right? Here in the US, it's a lot with addiction. In Mexico, I'm going there to give a talk in a couple of weeks, and I don't know if you know this, but racemic ketamine has been completely banned. So it cannot be used across the board. So it is not even an option for it because they have such a social problem with illicit substance abuse. And so I think it's that two-pronged approach of getting to a place in society. I mean, there's people that still will not recommend even the most bipolar, the stable bipolar patients for treatment in the depression phase because of the propensity they think that it has to provoke psychosis or to trip the patient into mania. So there are all these questions that I think clinicians need answered. And I think moving our narrative in research to answer some of those questions would be helpful.
Yeah, if we can go, maybe just one point, if we want to be provocative, is what is the scientific evidence for a protective effect of hospitalization in suicidal patients? And we all do that, and we really believe that it's the best way to protect patients from themselves.
Disagree. I think it's medical legal, but
there is also this aspect, maybe more in the US than in France, but it may not last.
That's the question that I had about the admissions. How long were the patients actually admitted after the infusions in the study? Until 6 weeks or shorter? Or?
Yeah, that's why I noted that we really need to have the same study with people who are not hospitalized, but because actually I don't remember the exact duration, but they were hospitalized for some weeks.
Yeah, we are actually doing a study like this without hospitalization.
All right.
And with ketamine nasal spray. So for the rest, it's almost the same as your study. Yeah, so we're very interested. But we suspect that the effect that you find is bigger than ours. We don't know yet, of course, because the blind has not been broken yet. But we don't see these numbers. But yeah.
Right.
And maybe it's because we don't. People are only admitted in our study for one day. And sometimes longer, but 90% of the patients are released the next day. So,
right.
Yeah.
But we expect that ketamine could reduce the duration of hospitalization. But the idea is if people are discharged earlier, would this effect that we observed be maintained, be the same? I don't know.
Yeah, we don't know. Yeah, we will see when our results are finished. But it's very interesting to compare the two studies.
Sure.
Yeah.
Okay, great.
Well, it would be great then to have that at Journal Club as well when the time comes, of course. Lisa, I just noticed that you had also another question about the durability of the response.
Indeed. And that's like coming back to the same question I think that was just posed. Like after the infusion, how do we measure that durability? And are we putting these patients back into the environment that they were in pre-hospitalization? And are we following those patients outside of it?
You mean in this?
Yeah, in this one, yeah. Did you in that period? What was the durability of the response?
Well, we followed them for 6 weeks, measure that during
Okay.
6 weeks. And so, and then we followed them, but we did not measure that. So I don't know how long after the 6 weeks the effect really was maintained. Yeah, the reassuring finding is that this effect lasted at least 6 weeks, which is, I think, a bit longer that was observed in some studies, where the effect could be lost after a few days. And for most patients, as you can see, at least those who are in early remission, this remission was maintained in terms of suicidal ideas.
How would you think through following up on those patients? Would you give them another 2 infusions? Would you bring them back for 1 infusions at 1 week? Would you do the same rating scale at 6 weeks and then follow them another 6 weeks?
I think there are many questions about that. So we don't know what to do, actually. Yeah. In those who initially respond and then the effect is lost. There is also the question of patient with borderline personality disorders.
Yeah, Sarah Feinberg, I think, had some data with borderline personality disorder.
So should we use ketamine in this patient? Should we use it regularly? I think it's a good.
Yeah.
It's because you're mentioning it, and I wanted to ask you, right, when you were looking at the trajectory of your patient, right? You have people in remission, you have people who don't achieve remission, and then you have this fluctuation, right, in suicidal ideation. So that made me wonder, if because you were allowing, for people with other affective disorder, what would be the contribution of UPD or borderline personality, if you had enough power to look at that, or even if you have that information?
No, we chose not to measure that diagnosis, the personality disorder. We are not, suddenly realized that I did not introduce myself. So I'm a professor of psychiatry in Paris, but I've been working on suicide for 25 years, that I first investigated in terms of neurocognitive approach and so epidemiology and treatments. And in our study, we thought that it's always complicated to have a good measure of personality disorder when we receive patients. And so we focused more on personality traits with different questionnaires than on clear-cut diagnostic criteria with their usual lack of validity. So I cannot say how many patients with borderline disorder we have, actually.
And I think we had some other question in the chat. And I hope I'm saying the name right, but apologies if I don't. Saidati, if you want to ask, or if you can understand them, I'm talking to you. I'm not so sure. But basically, sorry, it's not Fabrice delivery, but it's the phone. But the question was like,
so if you can hear me,
yes.
I'm wondering about the length of depression people might have been suffering before. Also comorbid issues people may have, because we see a lot of people with treatment refractory depressions have come in after years and years of treatment. So I would suspect that those people will have a less of a therapeutic response just for the one injection, one infusion. So I'm just wondering about whether you have noticed any duration of illness and comorbid issues have any implications on suicidal thoughts, because we practically doing, you had the luxury of seeing these patients in the acute inpatient setting. We don't do the inpatient, we do the outpatient. So we have a lot of outpatients coming with treatment refractory depressions. They have gone through the mill of treatments. In fact, they have ECT, they have other things going on. So measuring their suicidality and with one infusion doesn't seem to be clinically meaningful, at least in my mind. So the duration of illness and what else might have happened in their brain. And so I just wanted to have some discussion about that.
Okay, it's again a very good question, and I think it's something we have to do. We have to analyze in this sample the effect of different comorbid disorder. You were speaking about trauma, anxiety. We already spoke about anxiety, and yeah, and duration of illness. We probably have the information, so it's something we're gonna have to take a look at. Thank you very much.
We have another question for Armagan, asking if the hopelessness scores have improved throughout the trial.
Yes, absolutely. All secondary outcomes improved, actually. Depression, hopelessness, psychological pain. Just physical pain did not improve because the baseline score were quite low in this population, but yeah, they all improved. It's also something I want to take a look at, the dynamic of improvement as compared to the dynamic of improvement in suicidal ideation. So is there a difference, or do they improve all the same speed, or there is this question is to what extent the effect of ketamine on suicidal ideas is related to a general effect on depression. It's not so obvious, I think.
And also you mentioned it now, you had those scales on physical pain and psychological pain, but it seems from what you were saying at the beginning that the physical pain was a better predictor compared to the psychological pain. Was this like a bit finding that surprised you, or what sense do you make of it?
Yeah, a bit disappointing too, because it's, yeah, there's a discordance in findings. So it looked like the effect of ketamine could be through an effect on mental pain, and then mental pain does not predict at all the remission. So how do you do with that? I don't know. It's I don't know if it's a kind of statistical trick or whatever, but I have no explanation, to be honest. Yeah.
Julian, do you have another question? I see just at the very end of the chat.
Yeah, I wonder what is apart from ketamine, the regular way of treating suicidal patients in France. Is it very usual to admit them to the ward, or is it also usual to treat them as outpatients? Do you have any crude percentages for that, maybe? Or yeah,
So
I just wonder what
I don't have any stats with suicidal patients. I have only stats with patients who attempted suicide. So in people who attempted suicide, we know that around 30% will be hospitalized in psychiatry. I mean, 30% of those who attend hospital will be hospitalized in psychiatry, and 70% will be discharged home. So these are national stats. I don't know about suicidal ideas. What we know is that younger doctors tend to hospitalize more. This is a classical thing, and with time, with experience, you are following them more often, right? I think we should keep in mind that most people with suicidal ideas will not attempt suicide. These are stats, right? What we call now the transition rate. There is a recent meta-analysis of different cohort studies showing that the transition rate range between 5 to 30%. So at maximum, 1/3 of patients will attempt suicide. So most patients with suicidal ideas will not. And most people who attempt suicide will not die from suicide. Although this is what we fear, right? It's death, but it's a very rare event. And another thing is that our predictive abilities are very low. So many studies show that, even experienced clinicians, when they try to predict the occurrence of a suicide attempt, will fail to do that correctly. Okay. So we base our judgment on not on stats and on a clinical judgment which is not very good. And to do that, and then we decide to hospitalize these patients, and sometimes against their will. And we know that hospitalization in psychiatry could be stigmatizing, could be, lead to trauma. We're speaking about trauma, but we tend to, underscore the importance of trauma in patients who have been hospitalized. Also, there is a high rate of suicide in hospitals, and just after discharge. So I'm not against hospitalization in psychiatry, right? But I think clearly we need to reconsider the way we care, with patients, with suicidal patients. We tend to hospitalize them, and this is not always a solution. And when we hospitalize them, as I was saying, we tend to give them treatments that are sometimes dangerous and without any scientific evidence.
And for your study, they were admitted, the patients?
Yeah, this is what the regulatory agency requested, that
the
they
board
are
wanted it.
hospitalized. The same for the study with buprenorphine. We wanted to give it as outpatients, but they say no way.
But normally, if they wouldn't have been in the study, they might also be outpatients if they wouldn't be in this study.
Yeah.
Was there any analysis of prior suicide attempts in this cohort of patients versus the chronicity of their suicidal ideation before they were hospitalized? And did you look at the responders in those groups for the chronicity of their suicidal ideation or previous attempts versus this one that you hospitalized them for? Does that make sense?
No, not sure. But
so if I came to the hospital and I was a prospective patient for this, you hospitalized me, did you look at, in this current attempt, I had this suicidal ideation, but I'd had 4 or 5 attempts before, versus somebody, this was their first time episode, and measure those responses by those 2 groups?
Right. No, I did not check that, but it's again something of clinical characterization, how much it could influence response.
But I think, Fabrice, you showed some data, or was on the paper, on the number of suicide attempts that I thought was lifetime.
What I presented was the rate of history of suicide attempt, personal history of suicide attempt, but I did not present any past, number of suicide attempt or age at first suicide attempt or things like that could, be interesting to take a look at.
For sure.
I think we have time for a couple of more questions. I see that Phoebe and Jennifer have popped something in the chat. Would you like to ask yourself, or we're happy to read them out otherwise? No pressure.
You can read mine out.
Okay. So after hospital discharge, what is the protocol for follow-up care to encourage positive changes and avoid further suicide attempts?
You mean in the study or in general in France?
Are they not the same? Did your HIC committee not compel you to use the same standard of care? Are they different?
You
In
mean
the study versus in France, did you use a vastly different protocol than you would for general practitioners in France who weren't part of the study?
Yeah. So I think the practice in France is very heterogeneous. Clearly, it's very difficult to give an opinion on that because you see very different things. This study was conducted in academic centers, I think, with some interest in care to suicidal patients. However, there was no protocol that we wrote to say what should be done, and the idea was do as you're used to do, right? With these patients. What we do with very suicidal patients and after hospital discharge is first, which is recommended, is to see them very quickly after discharge. And there are some arguments for that. It's not RCTs, but there are some arguments saying that if you can see them within the first week, give them an appointment, ideally, with a same doctor or resident who followed them during hospitalization, much better. So they should be seen, they should have an appointment, they should know that they can call if something wrong. Clearly, it saves life. So this is one more important thing to do. And then what we do is, classical outpatient consultations with psychiatrist and, if possible, with a psychologist, which is an issue in France, and still an issue in France is that psychologists are not, the cost for psychologists are not covered by Social Security. Yeah, so only doctors and not psychotherapists. So it's changing slowly, but it's still a low coverage, so it's not very interesting for psychologists actually. It's changing for young people. They can now benefit from specific help. So it means that it's very complicated if they are not at the hospital to benefit from a psychotherapist help, except if they have a private insurance that covers that, or if they have money to pay for that. So again, this leads to some discriminations and heterogeneity in follow-up, to be honest. In our hospital, we also have groups, different groups, and specialist care for people with trauma. We're speaking about trauma or borderline personality disorder, etc. So then there is no homogeneous protocol. It's more dependent on the patient and history and what the patient wants also, of course.
I think, Fabrice, just at the very end, Jennifer was asking if you did withhold benzodiazepine prior to ketamine infusion. We know placebo was saline, and I think half of your sample was prescribed some anxiolytic, so maybe helpful to know.
We did not, actually. We did not.
Okay. All right. Well, with this one, I think we came towards an end. Our session, it was a very interesting presentation, and I really enjoyed the discussion that followed. I hope you did as well. Fabrice, thank you so much for coming. It was a pleasure to have you at the conference a couple of years ago, and a pleasure to have you here today. As I mentioned earlier, the talk will be available through our website and our YouTube channel, but it will take a bit longer because our IT expert is on vacations, but bear with us, it will come up in maybe in a week or 10 days instead of the usual couple of days. I hope to see you in Oxford at the Ketamine conference if you're interested, from the 25th to the 27th of March. We have a stellar cast of speakers also this time, so I hope you can join us. Thank you so very much, and hope to see you soon. The Journal Club will return after the Ketamine conference, so we'll see you again on April the 9th. Thanks a lot.